I'm doing pediatric for almost 6 years now. And all this period, we are dealing we're having tough questions about infant nutrition, what to feed them. First, I don't have any financial relationship with any commercial. Today in our talk, we'd like to know what to feed infants in the early infancy, mainly in the first 6 months of life. And of course, the best formula is the breast milk. And it is a difficult question to me. It is never over phone call when mothers ask, what should I feed my babies? By any means, I don't have breast milk. So then proteins in milk, so is it high, is it low? Human milk oligosaccharides, can we do it? And what about prebiotics and probiotics benefits? We always smile in our clinics with having this healthy infants in our clinics. We love to see our kids like this. They're all our children, all these angels. So we have to know that this period, it is very crucial and important in life because infants, they triple the weight. If he's born 3 kilos, he in the first year is 10 kilos. I cannot go from 80 kilos to 240 in 1 year, but these infants, they do. We have to supply good calories for the growth and for protein tenses, and we have to supply the suitable amount of fluid. So because they're always in the move, they have relatively high surface area. CNS, brain development is important because they need high quality of fat and later on will affect cognitive development. Skeletal development, they double the blood, they double the bones. So we need to pay attention to good source of nutrition for them. So in our clinics, usually we are happy, and once we're sitting with anyone will say, oh, you are a health worker. Okay, even when you're students either in medical school and nursing school, oh, please, what could I give to feed my infant? Oh, the simple question, yes, you feed him. But breast milk is always the best and the only best thing you can do, but it's feed him. It doesn't interfere with your life and even celebrities, they go for breastfeeding. This famous series, I think, stays tens of years. Lady Diana, her son, also they feed them. And nothing like the sense of bonding like will come from Dr. Yasmin later on, the bonding and breastfeeding. Also, Islam and encouraged breastfeeding for 2 years. American Academy of Pediatrics also, they say breastfeeding should go exclusive for the first 6 months of life and continue later on with weaning. Sometimes it is too much. I have seen 4 years old boy coming is still breastfeeding. Is it much? But the benefits of breast milk, it is optimum composition of nutrients and it help with the immunity for acute illnesses as well as for the immune mediated. So they will less diarrhea, especially in underdeveloped or developing countries. Diarrhea is a serious issue and less incidence of cell-mediated immunities. They increase the bonding, improve cognitive. They found in studies related to the duration of breastfeeding. They have less gases and more economical. They don't pay for in some areas, and even in not everyone is well paid like us, we suppose, but some people it's a burden. And it is always ready to use. It is sterile, warm, it is always there. Some mothers say, I will go only for 2 months. I will feed only till I go to work. I don't want. We try to encourage them. And we have to take care of the babies. The first 270 days is the pregnancy in his life. So we have to pay attention to the mother-to-be. Also weaning, when to start weaning and how to wean. Some children, we found the growth curve is doing well till the age of 6 months. When we start weaning, either they fall down or they shoot up. Some of the illnesses, usually normal infants, they compensate for the stationary or loss of weight during acute illnesses. Breast milk is very rich in high quality long chain polyunsaturated fatty acids, which is very important in structure and membranes of all organs. Actual contraindication of breast milk is very few. Active TB, until it is closed and treated. If mother is having an abscess, only from the side, if this abscess is opening to the ducts, or if she's having some medications, if she's having wet lesions of herpes on her areola, we stop. HIV in developed countries is a contraindication, but in developing countries, it is not, as the risk from dying from diarrhea-related diseases and malnutrition is more than the risk of dying from HIV infection. Infants, almost galactosemia is the only contraindication. Other during illnesses or he's having inability to swallow, we can feed by tube, cleft palate. We have special nipples for that. Of course, pediatricians, we know how to treat simple lesions of the nipple. We apply some creams and we teach mother proper latching. Mastitis, it needs antibiotics, hot compresses. If she have ignored the nipple, oh, please feed your baby. Usually, we don't put a fixed time. It is need and demand, and the baby hunger, it will be running the clock. And as we say, he doesn't have to cry when he starts to fast, sucking finger, moving the lips. We know it is time to feed the baby. So, what of any reasons mother, she cannot feed the baby? Breast milk is not available. So, and the baby start to cry. Everyone is upset, tears. So, also, I'm so upset if they cannot feed him. So the answer was, trust me, I'm a wet nurse. The first one who had a wet nurse was King Tut. And it was documented in his, on his grave, and everything was documented that he has a wet nurse at that time. Also, a prophet, he has a wet nurse, Sayyida Halima. And in the Middle Ages, this also people were having a wet nurse, and they put in the paintings, and they were having for them farewell parties when they finish, and they're leaving the baby after his wean. If for any reason we cannot have a wet nurse, so, and breast milk, which is the fantastic and the best feed for the baby, is not available, we start to look around us. We found the cows. Why we look to cows, not to monkeys, not to other animals? Because cows is everywhere, and they produce huge amount of milk, which is sufficient for this baby and for our babies also. But I don't think that's the suitable way to give feeds to our babies. And we thank God it is not the other way around. We don't have to give the cows our milk. So, as we know, we cannot give direct cow milk, and mothers will ask, why can I give the baby fresh milk? No, you cannot, because protein is not well digested, and it may cause micro-GI bleeding, and all this will lead to iron deficiency anemia, and it have also failure to thrive because it is not the optimal treatment. It is, this one is good. This milk is good for this calf, not for our boys. So in 1867, people, this Alaska, United States bought Alaska and became one of the American territories, bought it from Russia. And that time, the scientists, they thought that we should have a formula for our babies. They mix wheat flour, cow milk, malt flour, and potassium bicarb were developed. And that's the formula. But people after that, we start to look how much we really need. We know, as we know, the infant in the first year of life, almost 70 to 75% of body weight is water. And human and infant formulas, they should contain 80% of water with the optimum composition of nutrients. This slide is the important because it gives the answer that over the years, since that time till now, more than 120 or 115 years of technology is trying to make the cow milk a little bit humanized. Energy, we can supply the energy. Protein source, we have difference in the composition. We have the lactalbumin, and in the cow milk, lactoglobulin, and whey casein issues, very important. In human milk, it is amazing, 60 to 40 compared to the cow milk. So the fat, we can have the same, but the quality of fat is different. Human fat is very high quality compared to coconut and palm oil in the other formulas. Carbohydrate is lactose in both. So the milk formula protein component, say it is whey is high, it is alpha-lactalbumin, it contains lactoferrin, lysozyme, immunoglobulins, and the very important, as we come later on, the milk oligosaccharides, which is very important. They have nucleotides, growth factors, and cellular components. We will go to the quality of fatty acids, which is very high quality in the human milk. And the world, as we tell the mother, the world was busy. 1915, I think nobody of us was alive at that time. It was the First World War. People were killing each other, and our scientists, they succeed to make the first baby powder formula. They try to adjust this formula, contain cow milk, lactose, olive oil. They try to, they start to think about having easy to use formula for those, for few reasons, really cannot use mother or breast milk. 1929, that was Black Tuesday, the stock markets collapsed, and that time they start to think about soya-based formula. Soya-based formula was introduced in this at that time, and the American Academy later on considered it as a safe alternative to cow milk-based infant formulas, but it has no advantage over them. And just we had an agreement that infants with galactosemia were the very, very uncommon hereditary lactose or congenital lactose intolerance or deficiency, or parents sometimes say, oh, I want my son to go vegan, so I will only give vegan, so it is their choice. And those with documented IgE-mediated cow milk protein allergy, although half of them, they have also allergy to soya protein. So it had no value with acute gastroenteritis. It doesn't help with colics, and definitely has nothing to do with prevention of allergy. 1935, that was the biggest plane crash at that time. 56 people died, and at that time, that's the key here. They added protein to the formula, and they put proteins that they added between 3 to 4 grams per 100 calories. Was it enough? That was 1935. Today, nowadays, we are having the problem of obesity due to and overweight. It's huge burden affecting a lot of billions around the world. And one day lifestyle, fast food, everything with remote control, whatever the causes, but it is really a problem. And we have seen obesity is related to more than 30 diseases. Most of them, they improve with improvement of obesity. So we looked even more. Is it related to the amount of protein in our babies or infant formula? Professor Martina and the group, they carried a study for the European childhood obesity trial group. So they carried a study that involved 1,000 child. Half of them almost they receive high protein formula, and the others receive low protein formula, equal in the first year of life. And we added the breastfed infants as a control group. So, and we checked the obesity for the age up to the age of 6 years. So we found that high protein formula was associated with high BMI with significant p-value compared to the low protein and the breast milk formula group. So we found that high protein is associated with high incidence of later on childhood obesity and later on obesity in life. This was really a warning signal. So we recommend from this one to avoid high protein formulas. 1959, the end almost of Cold War, Nixon met Gorbachev, and that time iron was supplemented to the formulas. Iron is very important to the growth of children, growth of concentration, hemoglobin, and also we carried a study we took 40 infants, they have poor weight gain in the first year of life, just we supplement, they were having iron deficiency, we supplement only iron, and they continue to go later on to catch up, and they catch it the growth. So iron is very important to be to be monitored and to be added to the formulas, plus additional supplementation may be needed. 1962, there was a Cuban crisis missile threatening all the US, and it was very big crisis. And also that year, Marilyn Monroe died. If some people can remember her, she killed herself. And they start to look at this time to look to casein weight ratio. We start to alter all from the first slide, all trying to make the infant formula, the cow milk, and suitable, a little bit humanized. So we started to look to casein weight ratio with different amino acid and protein compositions, and weight casein ratio try to be similar to human milk. And 1984, that's the Vatican, and it was the year of United States have a relation again with Vatican after 114 years. And that was taurine was added to the formulas, and which is very important amino acid that help in absorption of fat and the integrity of the gastrointestinal tract and for the retina and for hearing. So it was added to the formulas. In the 90s, it was the Iraqi War, Gulf War, what we say, and that when we start to add nucleotides to the formula, which enhance the immune function and development of gastrointestinal tract, so it was added to our babies' formulas. This 2000, it was the September 11th, and that time it was the era and of hypoallergic formula, or hydrolyzed protein in the allergic formula. And this is very important. I usually don't like to give this form on just the phone. We have to take a little bit history on giving, prescribing formulas. Just we ask normal infant, normal formula. Those with positive family history of allergy in the SIPs or the parents, especially atopic dermatitis, we advise having partially hydrolyzed formulas before the gut is sensitized with antigens. Then, because as we say, allergy starts from the gut. It is the allergic march, GI allergy, then they have eczema, then later on they develop allergic rhinitis and hyperactive airway diseases. I'm sorry. Oh, I'm going back. So, and also, arachidonic acid was added. This decade, we're enjoying Egypt, Damascus, Lebanon, Beirut, Muscat, Oman, and Qatar, Bahrain, Dubai. In our fantastic life, it was now the era of human milk oligosaccharides. That's really because it was still the only deficient gap, almost was the human milk oligosaccharides. We'd like to add it. It was in the breast milk, so can we add it to the breast formula? To the formulas? Yes. Oligosaccharides is very important as a factor for the growth, biophytogenic factor, and it helps in growth of our children. So we added, as we see here, it helps in human polysaccharides. It gives us 10% of the energy needed in the breast milk, and it is the third largest component in breast milk. It helps to promote gut microbiota, which is very important in the balance. Microbiota is very important, not only preventing diarrheal diseases, but preventing pathogen from growth. It strengthens the barrier against allergic disease and educate the immune system, what we call the innate immunity. It helps to improve the immunity of the children. So, and also it enables the growth of other, say, pathogenic bacteria, including Campylobacter and other causes of diarrhea. The most important is 2FL oligosaccharides. This is the most abundant oligosaccharides in the human milk. So that was the gap, which defective in the formulas, which the scientists is almost succeeded to fill this gap. So the positive advantage of 2FL oligosaccharides, it is increase the number of beneficial bacteria and decrease the amount of Campylobacter, so it helps to protect the gut infections, innate immunity, and GI barrier. This era also we started about talking about prebiotics, which is nutrients that support the growth of good bacteria in the gut, mainly FOS and GOS, it's added. Also the probiotics as non-pathogenic bacteria, bifidobacteria and lactobacilli. It's added to the formulas, will enhance all the beneficial bacteria to growth. A lot of people, they discuss it may help as mainly, as we say, with the eczema, addition of probiotics. It's still the question, which one to add and what's the dose? We have almost agreement about few of bacteria to be added and the doses. A lot of studies were done, carried on, and they say it has antimicrobial effects. Some people, they say it has also anti-cancer as they inhibit the growth of carcinogenic cells, and anti-diarrheal, some anti-allergic, especially for eczema. Later on, osteoporosis in life, triglycerides, immune system, we know about it, and digestion and the other diseases. So we go back to our objectives of this slide. So what's the early infancy? Infant, what should we feed them? But it's milk. If not available for very few reasons, as Dr. Yasmin will tell us, it is suitable formula which give us what we want. Optimal composition, less protein, and human milk oligosaccharides. If it contain, it will be a great breakthrough, and also beneficial probiotics. So That's the formulas our baby, I call them angels, needed, and it's better to give with low protein formula. Can we add human milk oligosaccharides? Yes, we can. That was an achievement, and as we say for probiotics, suitable strain and suitable amount. I'd like to thank you for attendance and for attention. Thank you.
Sure. Okay, I'll start my presentation now. Okay, we are focusing mainly on the first 1,000 days. Why we are focusing on the first 1,000 days, it's a critical window to shape long-term health. The first 1,000 days, the pregnancy period, the first year of life, and the second year are foundation of building and programming our metabolism to build healthy adults later on. One of the main cornerstones in the first 1,000 days is the breastfeeding or the exclusive breastfeeding for 6 months, and to continue the breastfeeding through the 2 years. Even the WHO recommends us that we can continue breastfeeding beyond 2 years. We know for a fact that breast milk is a unique complex fluid with a composition that is species specific. It is it's dynamic in nature. It is unique for the nutrients of every child. It is the most appropriate source of nutrition for infants. Just the tailored nutrition for infants in the first 6 months of life. It evolves, it is dynamic, it changes according to needs. If the baby is sick, there are antibodies for this sickness. If the baby needs more nutrients, the breast milk changes to just accommodate for the baby needs. And the knowledge of breastfeeding is really amongst celebrities. It's everywhere. We all know for a fact that breastfeeding is best. Breastfeeding rates have decreased in the last decade or so because of challenges that the mothers are meeting of breastfeeding her child in public, breastfeeding her child in the working place. What is she gonna do? When you Google breastfeeding in celebrities, you find that they breastfeed everywhere, on the beach, while they're working, while they're out, while they're even in parties. So we should encourage this. We should support the mothers for this knowledge that this is the best for their children. Breastfeeding, breast milk, it is called the white blood. It is like our blood. It is the source of everything that is appropriate for the child to live a healthy life. It is the mother's gift to herself, her baby, and the earth. And over decades, we are continuing to discover new secrets. Not all the secrets of breast milk are revealed. And these are a few of the secrets. If we compare breast milk to formula, we find that breast milk has more than 300 components in its entity, from macronutrients, fats, carbohydrates, proteins that are specific for human milk, specific for the growth of the brain, specific for the growth of the immune systems, a lot of vitamins that are needed in their just right amounts, minerals, growth factors, immunological factors, antibodies, a lot in breast milk. The formula industry are trying just to cope with the breast milk, and as we said, the breast milk has a lot to reveal. So based on the facts, human milk is the WHO, World Health Organization, American Academy of Pediatrics, all the societies, they recommend exclusive breastfeeding for 6 months, and to continue breastfeeding along with adequate complementary feeding at 6 months and continue for 2 years or beyond. When I mean exclusive, no water is added during the first 6 months of life, no herbal drinks, nothing except breast milk. This is the optimum breastfeeding for the first 6 months of life. Let us look at our rates. If this is the best for our children, how are we doing worldwide? So these are the rates. We find that Middle East and North Africa, we have really 30% rates, and these are the improved rates. We were 25, and in the last 10 years or so, the last 5 years or so, we increased from 25% to 30%, yet I believe that we could do a lot better. Why it's important? It's important for a healthy child. It is the optimum nutrition, enhanced immune systems. The child who is breastfed have less chance of otitis media, ear infections, diarrheal disease, pneumonia, asthmas, allergies, childhood cancers, obesity, diabetes, even sudden infant death syndrome. This is evidence-based and research-based. So we compare a breastfed child. The breastfed child is healthier with a more competent immune system than children fed other ways. health advantage for the mother. Breastfeeding is really a hard task for the mother. So we have to encourage her, telling her that, well, she will have less anemia, less blood loss. She will lose weight because breastfeeding, around 500 calories are consumed per breast every day. It will protect her from ovarian cancer, from breast cancer later on. It will protect her from metabolic syndromes, type 2 diabetes. It will even elevate her mood and protect her from postpartum depression. So there's a lot for the infant and there's a much more for the mother. It's a mutual benefit. And there are specific target organs that breast milk would focus on: vision. Breast milk has protein, taurine, zinc, copper, fats, the omega-3. The main fat in the breast milk is the omega, antioxidants. All these nutrients are specific for the optimum functioning of the eyes, neurological development, optimum functioning of the brain and cognition, antioxidants, omegas, iron, thyroxine, glucose, galactose, proteins that are specific for the growth of the brain. And of course, we have the probiotics and the prebiotics changing the best gut microbiota ever, with consequence having the best immune system ever. Of course, there are other benefits for the economy. It saves money, reduced health visits. If my child has a better immune system, I won't go to the doctor a lot. With fewer visits, psychological benefits for the mother, improved moods, enhanced bonding, enhanced psychological stabilization of the child and the mother as well. So babies who are breastfed are healthier. Their mothers are also healthier. Breastfeeding is the ultimate preventive healthcare strategist. It protects from a lot of disease, from a lot of healthcare visits, and consequently will having a healthier adults and a healthier community. The magic in breast milk is it's dynamic in nature. What does it mean dynamic? It changes, as we said, according to the child's needs. It has bioactive fluid. It changes during stages of lactation. We have the colostrum, which is produced in the first 5 days post delivery, and it's a thick fluid. It's a thick yellow fluid, around 5 to 6 millimeters, and it provides a lot of calories, a lot of immunoglobulins, a lot of immunity for the child, yet less fat, a lot of carbohydrates to support this child. The total colostrum in the first 3 to 5 days is around 50 to 60 mils, which is more than enough for the child, because sometimes the mothers complain, I only have few drops. These few drops are enough. They are the first immunization for your child. Then the fats begin to increase in the transitional milk to end up with the mature milk with the composition that Dr. Ashraf discussed with us. It even changes within the feed. This is the foremilk, the first milk in the breast. The child takes, and it is mostly water and carbohydrates, so that the child, if he's thirsty, he wouldn't be thirsty, he would drink water. Then there's the hind milk that is rich in fat and that causes the satiety in this breastfeeding session. So for a child to have a complete breastfeeding session, he has to finish the hind milk, which is rich in fat, and he will be satiated. There will be satiety, he would sleep, and this is the perfect breastfeeding. So what can we do to support breastfeeding mothers? What can we do to increase our rates? What can we do to break the barriers and face the challenges that the mothers face so that they would stop breastfeeding? Our rates are 30%, yet 75% try to initiate breastfeeding. That means nearly 2/3 of the mothers, they are trying to initiate breastfeeding at first, then they fail or they stop somewhere in the first 6 months of life. And we end up at our rates of exclusive breastfeeding at the end of 6 months, 30%. Why did this happen? This is what we are going to discuss today. The first step to ensure success of breastfeeding is the kangaroo care. Once the mother delivers her baby, whether it's vaginal delivery or C-section, there has to be a skin-to-skin contact. The babies are bare, chest-to-chest, skin-to-skin with their mother. This supports breastfeeding. The baby searches for the breast. He is calmed down. He hears the heart rate of his mother. He smells her. He hears her voice. It reduces infant mortality and the risk of acquired infections and increases the rates of breastfeeding. And this is really a nice video showing us, this is just a boy that is delivered. He is even covered with the vernix. So we made the skin-to-skin contact, and he's searching for what he needs. He's a calm boy. He's attached to his mother. He's calmed, and he's just searching for the source, his source of nutrition, his bond. So he successfully reached his mother's breasts. And he successfully latched on his own without any help. So this is amazing. This is just nature. We interfere with what nature provides us. How can we overcome the difficulties, do the steps of the assessment, do proper assessment, how to store the breast milk, how to support the mothers? Breastfeeding assessment. Determine if there's a basic problem with breastfeeding by observing the mother breastfeeding her child. The first breastfeeding session has to be monitored and observed by a healthcare professional, whether it's a nurse, a physician, someone with the knowledge to help her with the latch on and the proper positions of breastfeeding. Step one is the positioning. It has to have comfort, suggest different positions, support nursing. If she has a C-section, support her as much as we can. The infant position has to be aligned. Head, shoulders, and hips are aligned. The infant's neck is straight. The head should not be turned to the side. The whole body is turned to the mother. The body is turned to the mother. As we say, the baby's stomach is in the mother's stomach. The baby's chest is in the mother's chest. They are facing each other. The infant whole body is supported, and don't push the head of the child to the breast. Let the child seek the breast on his own. And these are common positions. We have the cradle hold. The cradle hold is a very common position in breastfeeding, the most common position. Yet we have to adjust the position so that the baby is facing the mother and ensure that the baby is not turning his head to the side, because he will just not have an effective latch and he will injure his mother's nipple. Okay, we have the football hold. It is easier. The infant is placed under his mother's arms, and it is good operation, good position after the C-sections, because the baby is away from the wound, from the C-section wound. We have the side-lying position, which could also work in a C-section or in normal breastfeeding during the nights. And if it's a right position and it's the right attachment and right support, there's the rumor that the side-lying position causes a recurrent ear infection. This is not true if this is a correct position. The cross-cradle hold, ideal for early breastfeeding mothers. The mothers, they are able to hold the baby just under their arm. We have the straddle position, or the Australian hold, which is really effective with children with a lot of reflux, a lot of vomiting. And we have this sandwich hold to help in flat nipples or babies who are unable to suckle as they should with low tone, like the Down syndromes and the babies with hypotonia. Can we breastfeed twins? Yes, successfully we can breastfeed twins with the football position, with the football and cradle, and we have a lot really to manage a mother with twins, and we can support her to breastfeed her child exclusively or just give supplementary, sometimes formula. Do not let her get in despair from the early first beginning. So step two is the correct latch on. Use of the C-hole to make a sandwich for the baby to latch on, forefinger underneath, thumb on the top of the breast, acknowledgement of the rooting, middle of the, we stroke the infant's lip with the nipple. Infants open his mouth wide, then the mother introduces the breast to the infant's mouth. This is the good attachment. It should fulfill infant chin touching the breast, his mouth is wide open, his lower lip is turned outwards, both the lips are turned outwards, more areola is visible above than below his mouth, hearing the sound of swallowing, and the nipple after the breastfeeding is long and round. This is the steps of an effective latch-on, effective breastfeeding technique. Just let the child seek the nipple. When he opens his mouth, then we introduce the breast. Then the nipple is in the palate. It's not, the child is not sucking on the nipple, because the most common cause of stopping breastfeeding is the mother having pain during a breastfeeding session. This is not allowed. Breastfeeding is not a painful session. It's not a painful procedures. It shouldn't have pain. If the mother is in pain, this means that the latch on and the position is not right. We have to correct this. Otherwise, there will be fissuring and in her nipples, and then the pain would be severe and she would stop the breastfeed. So we can see two children. This is the child with the chin touching the breast. The lips are outwards. This is a perfect latch. Okay. On the other hand, this child, the lips are curled inwards, and this is, of course, a long latch. Okay, revising the latch. Signs of incorrect latch. Infant cheeks are indenting during suckling, clicking noises, lips are curled inwards, maternal pain and discomfort. It's the major point that we have to revise. If she is in pain, we have to correct the latch on and the position. This is, of course, wrong. This is also wrong. All the lips are curled inwards. This is not good latch. The one on the right is wrong. The lips are inward. And the one on the right is the perfect latch. So we have also, after ensuring step 1 that the latch on is correct, the position and the latch on, step 1 and 2 are correct, respect the hunger cues of the baby. We have to respect the early cues, because once the baby cries, he's in the late stage of hunger. He will be irritable to the breast, will not be able to breastfeed correctly or evacuate the breast correctly. So we have to respect the hunger cues. Early cues, stirring, mouth opening, turning to the sides. Mid cues, stretching, he starts to stretch, increasing the physical movements, okay? Late cues, he's crying, agitated body movements, color changes. This is not good to start a breastfeeding session, because he will probably not be able to breastfeed correctly. We have to calm him and then start the breastfeeding. Ensure milk transfer. Hearing the swallowing, sucking begins with rapid bursts, then it slows down. Undulating action, no stroking, friction, in and out movement, hearing a lot of kissing noises, as we call it. Milk extracted by peristaltic action from the tip of the tongue to the breast. The signs of effective breastfeeding, the most important sign. I'm weighing this child and the child is gaining weight. Of course, we can hear the intermittent episodes of rhythmic suckling. The mother is changing diapers, 6 to 8 weight diapers a day. That means he's not dehydrated. He's taking his enough fluids in breast milk, and 3 to 4 bowel movements every 24 hours. It can reach up to 6 to 8 bowel movements, as they are yellow, curdy stools. Average daily weight gain, the most important point is the average weight gain of 15 to 30 grams. If the mother is telling me I'm having low milk supply, my milk is not enough, I feel that my milk is diluted. If the child is gaining the enough weight that he's gaining, that he should gain, this is effective breastfeeding. We will continue breastfeeding, definitely. We have to respect the stomach size of the child. Day 1, it takes 5 to 7 mils, which is the colostrum. This is the maximum capacity of the stomach. We don't feed a child who is just born 30 mils of formula, or 30, or give him glucose, or giving him any other thing than the colostrum, which is the first immunization. It is 5 to 6 millimeters. This is the stomach capacity of the child. This is what he needs. Of course, the stomach capacity increases, reaching around 150 mils at the end of the first month. So what are the challenges? We have local challenges. Engorgement. Why does engorgement happen? No effective evacuation. The baby is not breastfeeding. There is pain. The baby is not evacuating, because the stimulation of the nipple is what produces the milk. And the oxytocin, it was causes the release. If it's not stimulated adequately, this breast is not evacuated. We have to prevent the engorgement. Early frequent feeding, unrestricted suckling time. The baby should breastfeed on demand, correct suckling and position, alternating breast massage. We can give whole thing, cold packs, hand expression or pumping. The only measurement is evacuate this breast, because if we did not evacuate the engorged breasts, it will cause lactational mastitis. Okay, it will cause inflammation of the breast and then later on abscess. If we're having nipple thrush or candidiasis, dry nipples, antifungal given to the child has whitish discoloration in the mouth with diaper rash, and the mother is having sore nipples. This is nipple thrush. We have to give antifungal treatment to both the mother and the child. Sore nipples and fissures, correct the latch, correct the position. If there's an infection, give an antibiotic. If there's dermatitis, give emollients. maybe it's biting to correct also the latch of the child. This is the lactational mastitis. The mother begins to be feverish after engorgement, red hot, tender and painful breast. Of course, we are giving analgesics, antibiotics, bed rest, and continue evacuation of this breast, or else it will turn to an abscess. When an abscess, we have to drain. We do not stop breastfeeding. We can evacuate and give the child the milk, or we continue breastfeeding from the other breast. We do not stop breastfeeding whatsoever. If the mother is having inverted or flat nipples, we can do techniques to help the nipple. We can use some prosthesis, like a synthetic nipple, or we can use the inverted syringe pump technique just to help her. It does not stop breastfeeding. It does not cause difficulties in breastfeeding. Just give the nipple to the child as much as we can, and the child will draw the nipple outwards. Are there any medical challenges that we could have in breastfeeding? The only indications of formula or mother should stop breastfeeding if she's having HIV, and this is in developed countries, or active untreated TB, or herpetic lesion on the breast. Active herpetic lesion on the breast, we continue breastfeeding from the other side till the lesion is crusted, then we continue breastfeeding from the affected side. If the mother is on anti-cancer, radioactive isotopes, or on drugs that are not compatible with breastfeeding, and we can search every drug the mother has on a website or an application that is called LactMed. We put the drug, is it compatible, is it excreted in breast milk or no? And we can continue breastfeeding. Most of the 95% of the drugs are compatible with breastfeeding. So we just have to check if the mother is on a drug. Of course, there are reasons in the child. If he's having some inborn errors of metabolism like galactosemia or phenylketonuria, then we have to shift him to a special formula. Should the mother breastfeed if she's having hepatitis A, B, and C? Yes, she should breastfeed. If there's hepatitis A, it's infectious, yes, but the mother has the antibodies in her breast milk. We give the child the immunoglobulins, the antibodies against hepatitis A, and we continue breastfeeding, taking all our hygienic precautions. If she's having hepatitis B, which is highly infectious, we give the child the vaccine and the immunoglobulins in the same setting, and the mother continues breastfeeding. If there's hepatitis C, there is a risk of transmission less than 0.0%, especially if there's are fissures and there is blood in the nipple. We treat this nipple. When the blood stops, we continue breastfeeding, and we continue evacuating this breast. Even if the mother is receiving interferon therapy, we can continue breastfeeding. What about COVID-19? At first, we used to separate the mother from the child. They give some express breast milk. The WHO had the recommendations, and the UNICEF in April and May, that all mothers with confirmed or suspected COVID-19 continue to have skin-to-skin contact and to breastfeed. If the mother has COVID, we do the rooming in. We allow her to be with her child. We give skin-to-skin. She just has to wear her mask and wash her hands, because actually COVID is not transmitted in breast milk, and the antibodies are given in breast milk to the child. What about diabetic mothers? Nursing mothers, we encourage them to breastfeed because they have lower insulin requirements, better glycemic control. Just be aware if she's taking an oral anti-diabetic drug. So when do we need to express breast milk? We are not able to do the latch on and the positioning. If the child is premature or he's in a NICU, if he's hospitalized, if the mother is working, we need to express the breast milk. The best way of expression is hand expression. It is really easy when we teach it to the mother. It is handy, it's feasible, or everywhere she can express if she's working in a special room. So hand expression, we teach all mothers how to hand express the milk, and of course we can use the pumps. The best are the electric pumps. The manual pumps are really tiring in expressing the milk, so the best are the electrics. This is the way to hand express. We just hold the breast at the areolar level. This is the C-shaped, and we just push against the chest wall, and then the milk is expressed. She can express up to 150 mils by hand expression. These are different breast pumps, and as we said, that we prefer the electric pumps. For how long should the expression? When the flow of breast milk slows, the mother can express in the breast milk. As long as it's flowing, she can express. The let down occur more than once. If she's breastfeeding from the other side, This helps the expression on the other side. She can pump and breastfeed at the same setting. How can we store the express breast milk? Okay, if it's room temperature, 25, 26 degrees, up to 6 hours. Refrigerator, in the door of the refrigerator, 3 days. Freezer compartment in the refrigerator, 2 weeks. Freezer compartment with a separate door, 3 months. And the deep freezer up to 6 months to 1 year. Remember, when pumping, to keep breast milk in the freezer, it's best to cool the milk down in the fridge first, where by gradually cooling this, a lot of natural proteins are maintained. How are we going to thaw frozen breast milk? If I'm going to prepare a breast milk that was frozen, we have to leave it at room temperature or just put it in warm water. Microwaves are not allowed. Heating the milk is not allowed. Just leave it in the room temperature until it's completely thawed. What about the misperception of having enough milk? Do they need help? Maternal factors, infant factor, external influences. The infant, if he's premature, maybe he's not suckling enough. The more you suckle, the more the milk is produced. If he has neuromotor delay, sucking and swallowing disorder, reflux, malformations, we have to keep pumping, keep encouraging the mother to continue pumping and breastfeeding. External factors are the most common, and they are the highly preventable. Delayed breastfeeding initiation. If the mother is having C-section, I'm not able to breastfeed, I'm not going to put the child on the breast in the first 2 days. This causes delayed in the lactogenesis and delayed in the production of breast milk. As soon as he's born, he's putting skin to skin, he's roomed in, he's put on the breast as much as she can tolerate. Separation cause delay in the breastfeeding, the poor latch, the bottle feeding with the confusion of the bottles and the teats that we are giving cause nipple confusion. The baby is not allowed to pace himself, and lack of support for the mother. The mother can have actual loss of supply. Yes, look for thyroid disease if she's pregnant, contraception, starting solids early, not sleeping enough, having a lot of stress. Stress inhibits the production of prolactin. Or a working mother returning to work with no stimulation for more than 5 to 6 hours would really decrease the supply of her milk. We can have the assessment charts for her regarding the weight, the minutes, the diapers she's changing, the stool and the supplementation, the pumping time, and then we can assess how breastfeeding is working. Strategies to increase the milk volume, identifying any risk factors in the mother and the child, tactile nipple stimulation, skin to skin all the time, frequent breastfeeding day and night, ensuring complete breast evacuation at least 6 times a day, uninterrupted maternal sleep. She has to sleep at least 5 hours so that the stress is reduced and the volume can be maintained. We can use galactagogues that helps the production of milk. Herbal batter, okay, some evidence in the use of herbal, especially the fenugreek and the fennel and the dill. We do not recommend the uses of pharmaceutical galactagogues. Good nutrition for the lactating mother. She has to have balanced nutrition, my plate, half vegetables and fruits, a quarter of grains, carbs, and quarter of proteins. And then the last message is the 10 steps to successful breastfeeding. We have to have a policy that we are encouraging breastfeeding in hospital, training all our personnel, staff competency in giving the advice and ensuring that the mother is discharged with enough knowledge to continue breastfeeding, good antenatal care, provide rooming in, kangaroo care, support the mothers with support groups, supporting nurses, supporting physician, no supplementation. There is a breast milk code. We don't have, there are no advertisements, no available formula in the first, in the maternity wards or in the NICUs. Okay, the formula decision is only the physician decision. We do not advertise, we do not give it to them easily. It is not allowed. Do responsive feeding, respect the child hunger cues. Bottle teats and pacifiers are not allowed and are not also to be advertised. Ensure them that they are supported during their discharge home so that they can have the best outcome. Any breast that makes milk can make more milk. Cardinal rules: feed the baby, preserve and increase the mother's milk, support the mother. The support that we are doing to the mother would increase our rates with the best outcome. Inshallah. Thank you for your attendance. Thank you so much.
Thank you, Professor Yasmin, so much. It was very informative, very clinically or day-to-day practice oriented presentation. Really, thank you so much for taking us through the breastfeeding challenges and how can we, promote it in a good way. Thank you so much. We probably received lots of questions today. Maybe Professor Ashraf as well is with us.
Yeah, I'm with you.
Perfect. So we have Professor Ashraf and Professor Yasmin with us. Probably the first question for Professor Ashraf, do all infant formulas have HMOs?
Actually, not all of them. So you have to check which one fulfill, as you say, it's a choice. Number one choice is breast milk. And as Dr. Yasmin mentioned, we should encourage as much as we can breast milk. Then, if not available, sometimes we can go to mixed feed. Then we choose a suitable formula which will fulfill what we need, the amount of proteins and HMO.
Perfect. Professor Yasmin, one more question for you. How long can we preserve breast milk in the freezer? And as well, can we mix different amounts maybe at different time points? Can we mix them in one bottle?
Okay, this is a great question. How can we handle express breast milk? The freezer, the freezer is in the fridge, the same, so it can be preserved up to 3 months. If there's a separate compartment or a deep freezer, it can be preserved up to 1 year. We can, yes, if it's thawed at room temperature, the breast milk could be mixed, there's no problem.
Perfect. Another question for Professor Ashraf. One was saying we used to appreciate with higher protein content, but seems, as you mentioned, the lower ones are better. Can you elaborate on this optimized protein or lower protein concept?
The usual, as we say, the human breast milk contains almost 1.2 gram protein per 100 calorie. And when we start to enrich proteins, not me, the scientist, enrich the formulas with proteins, they start to give higher proteins up to 4 grams. Nobody at that time, we thought that high protein is related to obesity. Then when we start to have big problem of obesity and is increasing, so scientists start to look for reasons of obesity, a lot of factors. We start to look lifestyle, remote control, fast food, a lot of things. Then we start to look to the changes which we have in baby formulas. As Dr. Yasmin mentioned, a substantial amount of people, they go on formula, or whatever the reason is. So we found that high proteins are related to later on development of a child obesity. So we'd like to stick to formulas with less proteins, which is almost, will give us 1.2 to each 100 calorie consumed, as almost the human milk.
So perfect. Another question for Professor Yasmin. Can we try breastfeeding premature infants, or should we rely on pumping?
Okay, this depends on how premature the infant is. Priming the gut of premature infants, the premature infant has to be above 32 years. Of course, he's lacking the tone to breastfeed, so we help him by expressing the breast milk. We do the priming of the gut. We give him, if he's inserting sterile, or we can give him with a dropper or a cup, according to the infant condition. We prime the gut with the breast milk. Breast milk is associated with decreased incidence of necrotizing enterocolitis, decreased rates of sepsis, and better GIT development. So we give the child breast milk as much as we can. Even in Europe, they are giving them donor breast milk if the breast milk of the mother is not available. So this is the best for, as we say, priming and giving the best chance for the child for the best GIT and best immune system.
Okay, there is another comment on this. Would you consider human milk fortifiers at some stage?
Yes. If he's premature and he's not gaining enough weight that he should gain, we can fortify breast milk by common fortifiers. whatever is available in your country. We have a lot of fortifiers, and we need to increase the calories because the prematures have increased needs in calories and proteins as well.
Okay, Professor Ashraf, there is another question. Can you highlight the importance of probiotics in early infancy? Once more, probably you've mentioned it during your talk.
As we say, the human milk contains the suitable probiotics. The studies later on, we found the importance of probiotics in preventing acute illnesses, especially gastroenteritis and the real associated diseases due to pathological bacteria. So probiotic, it is beneficial bacteria. So it will inhibit the growth of other harmful bacteria, especially Campylobacter and the other bacterial associated with the real diseases. So supplying the formulas with suitable species of probiotics is recommended. And actually, American Academy of Pediatrics allows the addition of probiotics to the formulas, but still we need more studies about the suitable species and the amount to be added. So, as we say, all the technology during the last 120 years is trying to humanize as much as they can the formulas to mimic human milk as much as they can. And one point regarding premature, the Dr. Yasmin even mentioned in the lecture that the premature milk, the 26-weeker, his best milk is the breast milk of his mother, because God, the 26-weeker, this milk is the most suitable for him. So this breast milk is breast milk giving by mouth when we establish the coordination between sucking and the swallowing, which usually is achieved by the 34 weeks. So, but we feed them by NG tubes, for example, but it's still even in sick prematures, the breast milk is number one. Yeah, this another, because that was highlighted Yasmin in her lecture, and I did NICU for a long time, so it's very important.
Perfect. We have a couple of questions as well for Professor Yasmin. There are mothers that say that we do not have enough breast milk, and others were asking about the causes of reduction in breast milk supply, what can reduce the amount of milk available, and also what foods increase the breast milk supply.
Okay,
so it's two in one question.
This is what we discussed today. So it's a misperception or true low milk supply. This is the cornerstone really, because the mothers, they get frustrated and they stop breastfeeding. As we said, that the most important thing, that this breastfeeding is satisfactory, or the breast milk is enough, that the baby is gaining the enough weight that he should gain. Of course, besides having 6 to 8 diapers, changing the diapers means that he's not dehydrated and that there is adequate bowel movements. This ensured that this mother, because the mother worries a lot and she's under a lot of stress, at least in the first month postpartum. So if he's gaining, we just reassure the mother. If he's not gaining, we search for other reasons of low milk supply. Maybe she's not evacuating, the nipples are not stimulated enough, the baby is not on the breast at least 8 to 12 times a day. They have to stimulate the nipple, evacuate at least 6 times a day. Maybe she's having a hypothyroid disease. Maybe there is another pregnancy. There is too much stress. Stress produces hormones that block the lactation hormones. They decrease the supply. So this is why, from the steps of ensuring good milk supply, the mother has to sleep at least 5 hours a day. So we have to investigate, take a good history, support the mother as much as we can, and know for sure or know for real, is this a misperception of the mother, or this is a true low milk supply that we have to do an intervention?
Perfect. There is another question for Professor Ashraf. Can breast milk bacteria cause infection or enterocolitis or an illness to the child?
No way, no way.
Yeah.
This is never harmful. This milk is the best. It contains even antibiotic and antibacterial properties.
Yes.
So it's
The
amazing.
ultimate protection. It's the shield.
Protection, yeah, it is. It never harm. It never harm.
Okay, there is Professor Yasmin. Yeah.
I will ask one to comment about, even she mentioned about women when they got pregnant, again, mother. We recommend that they start to even continue breastfeeding the child,
Yes.
although they're pregnant, but they should even take care of their
continue.
They should eat well, balanced diet, high proteins, high calorie, because she's doing pregnancy, and as we said, Yasmin mentioned, consume a lot of calories to milk output. So
unless, of course, Dr. Ashraf, there's high risk pregnancy or there's a risk of losing her child. Sometimes the oxytocin causes contraction. Then this is medically, we have to stop the breastfeeding. Otherwise, she can breastfeed as far as she can go.
And it will never even harm the child, because there is
both of them know
that breast milk and pregnant woman may harm the infant. It never do.
Yes.
Okay.
Perfect. There is another question probably from Yemen. Is there any, are there any precautions that you would recommend in case there is, it's hard to keep the milk, the pumped milk clean or away from infection or something like that?
Okay, breast milk is clean. Breast milk is the we cannot say sterile. It is just yes. We have just to boil the bottle that we are preserving the milk in, and then put it in the fridge or in the freezer compartment. And it is there's no contamination, and we have to do the hygienic measures that we are going to do as much as we can.
Also, it should be a separate area, not in the kitchen, please. So
okay. Okay.
That's a separate area. So
not in the kitchen, not in the bathroom.
Yeah, sure.
Okay.
But the kitchen is highly contaminated. So just a special area for even formula and for breast milk. So if you cannot apply the sanitary precautions or hygienic precautions for pumped milk, it will be worse even for formula. So, but please away from the kitchen, special area.
Okay, perfect. Probably there are lots of questions here. Maybe for both of you, how long should the child be fed, and should he be fed on both sides each time, or one side each time, or how long should he be stayed?
Yes, this is another taboo. As we say, some doctors tell her you should breastfeed 15 minutes from this side, then 15 minutes from the other side. The duration of breastfeeding depends on the development of the child, how far he can suckle, how strong he can suckle. If the baby is just born and his tone is not that good, he may need 10 minutes to 15 minutes to evacuate the breast. At 1 month or at 2 months, he's much more experienced. He can evacuate the breast in 5 minutes. So it's variable. What the mother should do is to just ensure that her engorged breast is evacuated till the end, start breastfeeding the other side in the next feed, and there is no specific duration. Just ensure that the breast is evacuated. It's not 5 minutes, it's not 15 minutes. Maybe the child can take 5 minutes, maybe he can take 15 minutes. It's according to the development and the tone.
But definite, not 40 minutes. Okay.
Okay, 40 minutes too much.
How to latch. Okay, if he's latched well, as we mentioned, and even for a little bit borderline premature, we teach the mother how to simulate the suckling, so it helps a lot.
Yes.
But not a longer period, otherwise she will go to sores and she will have pains. This is skin. It will, skin all the time, it will have sores. So we have to just suitable, accepted time, very slow, immature. They may take 15 minutes, 20 minutes.
Yes, this is the maximum, yes.
That's the maximum.
Professor Ashraf, is there a link between breastfeeding and neonatal jaundice?
It is feed him. As Dr. Yasmin even mentioned the lecture, breastfed infants, they have less constipation. They pass more motions, so they improve the enterohepatic circulation and they will get rid of the bilirubin high. When we suspect breast milk jaundice, we don't stop. We don't stop even the feeding, as Dr. Yasmin mentioned, because breast milk jaundice will never harm the child. It will never go to dangerous level and it will never harm the child. Even with breast milk jaundice, we continue breastfeeding. All the protocol or all the practice of holding the breast milk for 48 hours, then we check again, then if the level is going down, so we say there's breast milk jaundice. If we are sure about that, we don't stop. We continue feeding. And it helps. We stopped this practice maybe, I think, 15 years ago, we stopped doing that.
Yes, totally agree.
I think we covered lots of questions. We still have some more questions, but we ran out of time and we probably covered most of the ones that were repeated or the ones that came first. So I thank the audience very much for their interaction and engagement. And I cannot thank more Professor Yasmin and Professor Ashraf for their very elegant, very engaging presentations today. And probably I leave a final word to Professor Yasmin if you need to give a final word, and Professor Ashraf as well if you have a final thought that you would like to share with everyone before we close. I think we received lots of questions on the COVID and breastfeeding. If you both would need to comment from your clinical experience as well. I think Professor Yasmin, you covered it in your session, but we still are receiving some questions on that.
Yes, because we have a lot of fears, yes.
Yeah.
Actually, we have we are doing a lot of screening, and in practice we found even it is the other way around. The infants are positives and the mothers are not. So we don't separate them. And sometimes if the breastfeeding is too late to separate, even if the infant he tested negative, he will test positive few days later. Just the mother will put mask and will continue feeding. There is no excuse to stop breastfeeding. Unless the mother is very sick, she cannot. That's a different issue. But thanks to God, most of the cases of the children we have are doing well COVID-wise. We did not lose any child because of COVID, thanks to God. Yeah.
Alhamdulillah.
Yes, totally would agree with Dr. Ashraf. We do the skin to skin, we do the roaming in, breastfeeding, just the mother has to wear her mask. She's protecting her child, she's giving him the antibody he needs, the immunoglobulins in breast milk, and the virus is not transmitted in breast milk. Even if he's tested positive, he's protected at the same time. So this is by evidence so far. The COVID is only 7 months old. So never to stop breastfeeding. And I would like to thank Dr. Muhammad, Dr. Ashraf, and the attendees for today's session. It was really enriching. Thank you.
Thank you all. I'd like to thank Dr. Yasmina for sharing this session with me. It was interesting always to listen to your lecture and our discussion together. Thank you, Muhammad, for hosting us and for this amazing evening. Hopefully we'll meet in person soon.
Inshallah.
We'll have face-to-face eye contact soon, inshallah.
Hopefully soon.
Usual, our life back, inshallah, soon. Okay, thank you all.
Thank
you so much.